Hello, everyone. I'm Francis Collins, the Director of the National Institutes of Health. Each year, my colleague Nora Volkow and I look forward to participating in the Prescription Drug Abuse and Heroin Summit, where we get to meet with you again and get to tell you about NIH's continued progress in helping to take on our nation's opioid crisis. But for the second year, we're joining you virtually because of the continuing dangers of the COVID-19 pandemic. I hope next year we'll be back together again, and I think there's a really good chance we will be. But for now, we're going to speak to you in this virtual format. While the constraints and isolation from the pandemic remain difficult for everyone, I think we've gotten pretty good at finding creative ways to bring people together, including this platform. So we can talk to you about how biomedical researchers are hard at work addressing the opioid crisis, and of course about the NIH with its HEAL, H-E-A-L initiative, helping to end addiction long-term. We announced HEAL only a few years ago. It is now directing more than $1.5 billion to researchers and communities all across the country. So what have we learned so far through HEAL? Well, one thing HEAL is doing is tackling the need for pain treatments that help patients avoid the risks of opioids. This research has uncovered new targets and therapeutics for a number of different types of pain, including neuropathic, post-surgical, osteoarthritis, and chemotherapy-induced pain. We're also now testing implanted devices, electrodes, and non-invasive nerve stimulation, looking at several complementary and integrative approaches like phone-based physical therapy for low back pain, for instance. We're developing an iterative model for chronic low back pain. In fact, multiple contributions to chronic low back pain and treatment interventions, from anxiety to tissue damage, from psychotherapy to surgery, to try to inform precision medicine for back pain, because it's not all the same. And of course, all of this is an effort to try to provide people with alternatives so that opioids don't become the answer they seek out, and which then ultimately does more harm than good. Through HEAL, we've also launched the first in-human test of a vaccine to protect against the harmful effects of opioids, including relapse and overdose. Additional studies of vaccines and even monoclonal antibodies against fentanyl and other opioids are underway. We're testing a tool that provides pharmacists with a validated opioid use disorder risk measure to better identify who is at high risk for opioid addiction and what kind of early intervention could actually be put in place. In spite of COVID, we are also continuing with our clinical efforts. Many studies are now recruiting participants. It's not been easy, but this includes family-based prevention programs, culturally tailored interventions for hard-hit American Indian populations, and interventions that address social inequities, such as lack of housing. And this will help assess how providing access to housing, along with preventive services, might protect homeless youth from opioid misuse and opioid use disorder. We are also making progress on the truly heartbreaking problem of babies born dependent on opioids. Early studies have found extraordinary variability among sites across the country in how many infants are born exposed to opioids and how they're managed. The NIH HEAL Initiative launched an innovative research study to test the effectiveness of a new approach to care that measures the severity of a baby's withdrawal based on the ability to eat, sleep, and to be consoled. This approach, yes, called Eat, Sleep, Console, helps provide appropriate treatment for these infants without the use of medication when that's possible. And we're following these infants over time, especially in the first 2 years of life, which is particularly critical, so that we can be ready to support them and their mothers in the best way possible. We're also developing novel technologies, such as a hospital bassinet pad that provides gentle vibration as part of a treatment for a neonatal opioid withdrawal syndrome. And that has received a breakthrough device designation from the FDA. But let's be clear, 2020 has been an extraordinary year for all of us. It has been tragic in so many ways, and lives lost, economic disasters that have fallen on families, and all of the stresses that have occurred across our nation and across the world. It's had a profound impact on how we do science and how we do research. It's also brought around dramatic changes to treatment and healthcare, and many of those are likely here to stay. Telemedicine, by necessity, has been utilized in ways that we would not have seen happen had it not been for this crisis. Well, the resilience and ingenuity of the scientific community has been impressive during all of this. Quick pivoting has resulted in some real gains through research. Maybe you could even call them silver linings in the midst of this terrible storm. So, for instance, expansion of telehealth services, expanding access to care, adaptation of interventions for treating pain and substance use disorders to virtual platforms, and new and innovative ways to engage and recruit patients through a combination of phone, video chat, and texting. So in these times that challenge our community, making it hard to support colleagues and people in need, we at NIH can do a lot to help. We have been doing those things, and we aim to continue as we move forward and seek to find our way out of this difficult year into a better place. But here to talk with me about all of this is the person who I go to when I really want to understand the science of opioid use disorders and other types of drugs that can cause addiction, as well as somebody who knows neuroscience and understands all the details about how these particular substances affect the brain and affect human behavior, and who also brings to this incredible dedication to try to help those who have been caught up in this very difficult circumstance and are seeking a way out. So without further ado, let me bring in Dr. Nora Volkow, the director of the National Institute on Drug Abuse, and we'll engage now in a bit of a conversation, just as if we were there in front of you in a hotel somewhere, and all of you were able to listen. And we'll get to some Q's and A's in a bit as well that have been submitted through our HEAL initiative, because they knew we were going to do this, and they have submitted some questions they thought you might want to be listening to the answers as well. So Nora, welcome. When we spoke last year, we were just starting to see how the COVID-19 pandemic would affect substance use, addiction, and overdoses. Now, a year later, we know more. And what we're seeing is a source of deep concern. So tell us what has been at the forefront of your mind as we have watched things unfold over this past year.
Well, Francis, first of all, it's a pleasure to be here with you. And I want to say hello to everyone in the meeting. And I do hope that next year we are there in person. Last time when we did it 1 year ago, and I was reminiscent about it, because we were going into a new world. We didn't know what to expect. But obviously, we were both concerned that the stress associated with the pandemic, with the unknowns, which are factors that have been recognized for many years to increase drug use, would not be a good recipe for the problems that we were already fighting with the opioid pandemic. So we had therefore predicted that the COVID pandemic would exacerbate the vulnerability of people to taking drugs, and that if we were not able to accommodate for their treatment needs, then that would result in relapse and very adverse consequences. On the other hand, one of the issues that we did discuss was perhaps the possibility that by closing the borders, it would be harder to get drugs into the communities and therefore could have a protective effect. What I can tell you offhand, the latter did not happen. And unfortunately, what we have seen is that the stress of the uncertainty has actually resulted on what we see an increase in drug use of all types across the country. But importantly, since we're dealing with an opioid epidemic, we have seen an exacerbation on the opioid epidemic as evidenced by the number of people that have died. Mm-hmm. And CDC, which is the agency that monitors with greater accuracy the outcomes associated with overdose deaths, in the preliminary data that goes out to July 2020, so it does not cover the whole pandemic, already shows that in the prior 12 months to July 2020, there was a 24% increase in mortality overall from overdoses. And within those numbers, it also noted that there was more than a 40% increase, close to a 50% increase in mortality associated with fentanyl, which are the synthetic opioids that have actually been responsible in the past 3 or 4 years for the very steep increases in mortalities that we're seeing in some places. We're also seeing that an increase not just in the number of deaths from fentanyl and other synthetic opioids, but we've also started to see in the past 3 or 4 years an increase in the number of deaths from stimulant drugs like cocaine and methamphetamine. And the largest increases there have been with methamphetamine and very much driven by drug combinations. So what has happened is, on the one hand, we have the perfect storm. We have people very stressed to their limits because the insecurities, the decreases in economy, the loss of jobs, the death of loved ones, of the loss of friends. I mean, that's devastating. And then on the other hand, we see the dealers taking the opportunity of actually bringing in drugs that are now being distributed into a much wider extent than we had seen, which is the case for drugs like synthetic opioids and synthetic stimulants like methamphetamine. So that's where we are in terms of overdoses, but just in general sense. So I'll let you get back to the next point.
No, this is very important information, Nora. So on top of that, of course, people are also at risk of getting sick from COVID-19. What have we learned about the risks of this coronavirus illness for people who use drugs? Is this a double whammy?
Yes, indeed. Unfortunately, it is a double whammy. And when you look at the electronic health records about the outcomes of people having a substance use disorder, whether it is in the diagnosis in the past or a recent diagnosis, you consistently see an increased risk for them of getting infected. And if you look at those people that get infected, you also observe a significant risk, an increase in dying from COVID. And so you ask the question, well, what is driving this vulnerability of people with substance use disorder for getting infected, and if they get infected, worse outcomes? And there are two large cluster factors that I like to think about. One of them are the actual pharmacological effects of these drugs. And we know that basically all of the drugs of abuse that result in addiction, notably, of course, opioids, but let's not forget tobacco smoking, all of them damage the cardiopulmonary system. And some of them also damage our immune systems. And we know very early on that individuals that have any disruption on cardiovascular health, pulmonary health, immune function, metabolic syndromes are at higher risk of getting infected and having adverse outcomes. And so it happens, not surprising, that people with substance use disorders have many more of those comorbidities. But there's another factor that is as important. And I think that that's also one that's very tractable, and that's why I want to bring it over, which is the way that our society has overall dealt with substance use disorders, which is actually not treating them as a disease condition that requires intervention and support for recovery, but in many instances, criminalization without actually a moral judgment that does not provide the support and that alienates and makes the outcomes much worse. So the stigmatization of individuals with addiction, the lack of access to treatment, the social isolation, all of these factors have created havoc in making these individuals so much more vulnerable to get infected. They will not go to a doctor. They don't want to be stigmatized. They need to go out into the streets to get access to the drugs. Many times they don't have a choice of what drugs to take because they cannot afford anything but what's offered to them. So many of them end up homeless. And as you know, which is a very tragic story as it comes to differences in minorities, is a greater proportion of minorities are criminalized and end up in jails and prison. And we very well knew from the beginning, even before COVID, that prisons are jails, are places where infections actually transmit extraordinarily rapidly. Considering that there is an overrepresentation of people with substance use disorders, including opioid addiction, in jails and prisons, you could see rapidly why this was going to result in very negative outcomes for this group of individuals. So these are where we are as it relates to COVID, both the pharmacological effects of these drugs, these which are harmful to our body, and then on the other hand, the way that we as a society have dealt with the treatment of substance use disorder.
All very sobering. Nora, say a bit more about the trends then in drugs that are being contributory to the current crisis. You know, maybe 3 or 4 years ago, looking at those curves, what was going straight up was opioids, especially heroin, and then fentanyl coming up very fast. And of course, that has continued. But now we see more, from the data I've seen, from stimulants and from mixing together of different types of drugs in the same individual. Is that trend something that you can explain? What is the basis for which this dynamic has shifted over the last few years, or do we even know?
Yeah, we know one of the things, and Francis, yes, unfortunately, what you are describing is exactly what we are observing. We know that there is tremendous geographic diversity in terms of ultimately how people are responding to these drugs or favoring these drugs, and how obviously the accessibility, the type of drugs that you have accessible in your community, of course, is going to determine the likelihood that you would get exposed to them. What is also clear is that you recall at the beginning of the whole opioid pandemic, it was mainly focused, the mortality was mainly associated with white Americans, and many of them in rural or suburban area, semi-suburban areas, the area of the Appalachian states, the area of New Mexico and Arizona. Now that has shifted, and we're seeing more and more mortality among minority groups. And what's very tragic, if you then you say, I'm seeing two curves, it's almost vertical in terms of the rate at which the mortality from fentanyl has been happening into our country. And it's almost vertical if you see it also for the stimulant deaths. But when you try to dissect, I mean, what's driving it, you come to realize that the highest increase in mortality from opioids, predominantly now driven by fentanyl, is among African Americans, Black Americans. Very, very high rates of mortality during the COVID pandemic. And I think this is something that should lead us again to pause about what's driving these terrible racial disparities. And when you look at the mortality from methamphetamine, it's also very chilling to realize that the risk of dying from methamphetamine overdoses is 12-fold higher among American Indian and Alaska Native than about other groups. And I think that this sort of, again, shines the light on what we already know, that the most vulnerable individuals are actually going to have the worst brunt from what's happening right now. So yes, and so you tell me, well, why these drug combinations? Because it is correct that many of the deaths of methamphetamine or cocaine, it's estimated that 50% of them are linked with combination with fentanyl or heroin. So why is it happening? Because if you're a drug dealer, it becomes very appealing to be able to actually dilute that drug that you're interested. Say you have cocaine that has to come from cultivation in Colombia, it has to come the border. And so you have limited doses that you can sell. But if actually you dilute those cocaine doses and put a little bit of fentanyl, which is so incredibly potent, you're maximizing the intensity of the drug effects. And so you can, that's what they are doing. The dealers are lacing the drugs, even when they are not opioid drugs, in order to make a larger profit. And that's happening, again, all over the country. And this, you may imagine, right? I mean, of course, if you are someone that's taking heroin or opioids, you become tolerant to the effects of opioids, so you can tolerate higher doses. And that's why someone that has been addicted to heroin can take 1/10 of a dose, Francis, that would kill you or me, because they are tolerant. But someone that's addicted to cocaine or methamphetamine is not tolerant to opioids. And if they get a drug, a stimulant drug that's laced with a stimulant, they are going to have the same risk. Basically, if you or I get exposed to a large dose of fentanyl. And that is an element that has been contributing very much to the high rise in mortality from other drugs, not just the opioid, pure opioid. That is not the case right now.
Wow. I'm glad you raised the issue of health disparities here, Nora. I think 2020 will kind of go down as a remarkable year where we basically had to focus on 3 public health crises at once. One, of course, is the crisis of opioid use disorder and other drug use that's causing deaths. Another, obviously, was COVID-19. But the third one was the realization, although it's been there all along, that health disparities in our nation continue to be a major source of shortening the lives of far too many people on the basis of what zip code you happen to grow up in, having not much to do with your biology, but everything to do with the way in which our society still is afflicted by something that you have to call structural racism. And as we at NIH are looking at this circumstance, realizing that our own health disparities research agenda needs to be thought through. Clearly, what you see happening now with drug abuse and death is becoming more and more clear. We have not fully incorporated into that all of the other factors that play out in health inequities and racial inequities in our country. Well, gosh, we're all sounding pretty gloomy here. Let me ask you, Nora, though, about something that I think is a positive step for optimism. You were talking about how stimulants have particularly become more widespread and contributing more to premature deaths. But what about a treatment? We've had something for opioids. Do we have something maybe now for methamphetamine? Tell us about that.
Yeah, no, Francis, and I'll jump into it, but I do want to say that there is something like when you were saying it, it just hit my brain and you say, no, sometimes we have learned during the COVID pandemic to do things better. And I think that one of the things that it has actually awoken is the consciousness of our responsibility to do everything we can to basically get rid of the health disparities. And that is not something that I give for given. There is an energy, there is a momentum, the sense that we can do it. So that's why I sort of calling it, borrowing from others, the term after times. We are at a crossroads. We are at a moment where we can actually, by pulling together this recognition and the amazing resources that science bring to us and data, I think we can change. And so I just want to point the point that the fact that we're delineating these issues should not be seen in the negative. I want us, because it's there, it's factual. We need to use our talent to actually, and our ability to interact with one another to change it. And I do think we can change it, but it's not going to be automatic. As you have been very much invested with Unite. But coming to your question about the good news with what do we have for methamphetamine? For opioid addiction, we're very lucky because we have very effective medications, methadone, buprenorphine, naltrexone. And on top of that, we have naloxone, Narcan, that actually, if you administer it on time, you can save the life of the person. You save them. It's extraordinary. So we don't have that for methamphetamine. We don't have any FDA-approved medication for methamphetamine, and we don't have an overdose reversal for methamphetamine. So there is where we are in the science, and we are very excited that at the beginning of this year, we had funded a large clinical trial that was aimed to investigate the benefits of the combination of 2 medications that are approved on the one hand as antidepressants, but also approved for the treatment of smoking cessation and alcoholism. When combining these 2 medications, could we improve the outcomes on individuals with moderate to severe methamphetamine addiction? And it's the largest trial ever that we've seen a positive response. So it's very exciting. It shows that the combination of these two medications actually significantly improve the ability of people to actually inhibit the urges to take drugs and therefore to stay away from the use of methamphetamine. It's very exciting data. And what we want now to do, like anything else, is, in science, obviously replicate, but we want to tie that replication study with guidelines from the FDA. Why? Because we want that the FDA tells us what is it that they would need in order for them to approve a new indication for these medications. And why is that important? Because then we can have insurances pay for it. And that will increase the likelihood that people get treated with these new combined medications. There are other very exciting an area that I'm very excited in terms of possibilities is we're on phase 2 clinical trials for a monoclonal antibody against methamphetamine that actually, if it proves beneficial, will be able to give us the equivalent of an naloxone. So if you have someone coming into the emergency room with an overdose of combination of opioid and methamphetamine, naloxone will not revert it. But if you can then do the monoclonal antibody with an naloxone, you're going to have a much greater likelihood of success. And the other thing that's fascinating and promising is because of research on HIV and also research on cancer with monoclonal antibodies, now investigators have been able to modify the monoclonal so they are not degraded as easily as it was before. And therefore they stay in our blood for longer periods of time. And there's the possibility that this passive immunization may be able to be used for a treatment for methamphetamine addiction. So this is an area that we're very, very excited about.
Yeah, I think people are excited when they hear that you might be able to use the immune system as one of your allies in dealing with drugs of abuse. So that's good to hear that's making real progress. Well, Nora, in a minute, we're going to get to some questions submitted by some of the HEAL investigators and their teams. But first, since I'm going to talk about HEAL now, helping end addiction long-term, anything you want to highlight in the midst of COVID-19, where this has all been particularly tough, but progress you might want to point to for any of the programs within HEAL that are particularly important flagships?
Oh yeah, no, we are doing progress despite the difficulties that we have encountered, but it also illuminates how incredible the human brain is and how when we work together, we can solve this problem. So I want to highlight that there's been several successes as it relates to medication development. We're very interested on actually providing antidotes for overdoses with fentanyl that will be more effective in reversing overdose deaths. Those are proceeding. We're interested also in providing longer lasting medications for treatment of opioid use disorders that will go for 6 months, which is something that of course will improve the likelihood of patients being protected from overdoses. So there's a lot of excitement in the whole area of medication development. But we are also made some inroads that I think are quite remarkable, and that relates to our research that is going on in the justice setting. And as you know, the J-Coin is one of the big landmark projects for HEAL that actually involves a network of researchers that are working with judges and individuals in the jail and prison system that are responsible for taking care of these individuals with substance use disorders. And through this network, we have been able to learn from one another and to start to harmonize practices. And one of the things that has been very revolutionary, I would say transformative in the jail and prison system has been the actually embracing of telehealth. In the past, telehealth was not really very much of a reality in jails and prisons because of the fear of bringing these virtual worlds that could lead to communication that was perhaps considered that it could be dangerous. That has changed. And now this brings the access to treatment for individuals that are in jail and prison, many of them with substance use disorders, many of them with mental illness. And that is an amazing resource that can be utilized properly. Also, because of the situation of COVID, as you know, many of the individuals that were in jails and prisons were released, those that were nonviolent. And those gives us an opportunity to evaluate how to ensure that individuals with a substance use disorder that otherwise have not been incarcerated, ensure that we can help them achieve recovery. So hopefully we can take that data as evidence that there are strategies that are much more effective than incarceration when it deals with addressing substance use disorders. And there are also many of them starting to open up the possibility of bringing medications for treatment of opioid use disorders, bringing more flexible policies that enable for the individuals when they leave jail and prison to have access to their insurances. So we are maximizing that network to obtain data so that we can then use that data to to illuminate what are the interventions that lead to the best outcome. So that's one. And the other one relates to the one that you were commenting, Francis. I think that the healing community studies, which is in Massachusetts, New York, Ohio, and Kentucky, 4 of the states with the highest rates of mortality from overdoses from the inception of the epidemic, actually are part of this very ambitious study to implement a battery of interventions for which there is evidence of benefit. And so the issue is, here we are, I mean, the middle of this study, very, very ambitious, which aims to decrease mortality by 40% in 2 years of implementation. And here COVID comes, and everything puts us upside down, because what our predictions were based are actually shifting all along. But because we had consolidated the interactions between agencies, it enabled us to more efficiently apply support system in those communities. And that has been very, very reinforcing. And 2, it has also enabled the collection of data in ways that help us guide how to intervene better. There's obviously been delayed in implementation of interventions that require being in place or that require the emergency departments, because now the emergency departments are saturated with taking care of COVID patients. But we've learned a lot in the process, even though it may have not been our initial goals. And you may tell me I'm basically maybe too optimistic, but I do believe that we can stay on goal. Unfortunately, the pandemic has seen in Kentucky the highest rates of mortality that they've ever seen in that state from overdoses. So nonetheless, I think that the moment we start to implement the evidence-based interventions, we will start to see a turning of that point. So these are 3 of the highlights. They are not the only ones, but I realize that you said to me, Nora, do you want to highlight some of them? So
I appreciate that. And yeah, not a minute too soon to get those things opened up again as we come out of the far end of this terrible COVID crisis. Well, let's transition to a few questions provided by people who are subscribing to the HEAL website. And at the end of this, I'll give you a link so people can scribble down the HEAL website if you haven't already signed on to that. Remember, HEAL was announced at this very meeting at the Prescription Drug Summit 3 years ago, and involves research participants and patients and stakeholders, and especially people with lived experience with pain, addiction, or both of those. So they have submitted some questions, and I'm just going to go through maybe a few of these in the time that we have left. And let me start with the first one. Pose this to Nora Volkow. What is NIH doing through the HEAL Initiative to address the stigma that prevents people who need opioid medications for treatment from getting them?
Very important question and crucial one. If we do not address stigma, we are not going to be able to bring treatment to individuals with substance use disorders. And in fact, right now, for example, we are having from input from researchers out there in the field, there is also mistrust of many of these individuals for vaccination. So we need to address the fact that we have been stigmatizing substance use disorder. We've been stigmatizing that treatment. And some of these things are quite structurally determined. I mean, it becomes, first of all, to me, it has been wonderful to see how the science has resolved with products, the vaccines that can make the difference on the pandemic. And so now the challenge is to actually implement them. But I also become aware that there is a very large difference in terms of the investments that we have for different diseases. And the same thing is true, for example, for access to data. The data that we had from COVID, which again has been amazing and very useful for all of us to guide policies, is immediate. Basically, on a daily basis, we're seeing how many people are getting infected, how many are going to the hospital. That's not the case for the substance use, for the opioid crisis. It basically takes us more than 6 months to know what's going on. And yet we know that there are technologies out there that could help us accelerate us. So I do think that as we look at the issue of stigma, we need to recognize that there are structural issues of how our society also is stigmatizing the importance of substance use disorder and the investments that we should give to them. And I do want, because substance use disorder don't just exist in isolation, frequently comorbid with mental illness. And that also in many instances pertains to mental disorders. So we are the first lesson, and I think that this is a lesson that we all have learned in certainly from NIH, and you have led the effort, Francis, is we need to listen. We need to understand and not just think that we know better. And that has, to me, been clear cut that some of the issues that we believe are the ones that are most problematic are not. And that process of having sessions where we listen and where we will learn from one another and we empower those communities to speak up and help them do so, they are probably one of the most important things that we can do in terms of addressing stigma for addiction, addressing stigma for other areas of medicine and in disparities clearly.
Yeah, absolutely. And the HEAL Initiative does have within its research portfolio a number of research projects focused specifically on stigma, coming up with various tools that can help reduce this. It's not just the general public that sometimes has these attitudes, providers as well, or the ways that we can assist with that in terms of various kinds of educational tools. So we see this as a really critical issue. I'm glad the person asked the question. Second question, in small communities, how can we provide more access to medications for opioid use disorder? Yeah, especially in the face of COVID. So Nora, how have we seen small communities managing this when many of the things that were previously counted on in terms of methadone clinics or buprenorphine prescribing, how has that been adjusted to in the face of this requirement that everybody has to kind of stay at home?
Well, again, human innovation, and one of the projects that that actually was funded as a pilot through the Clinical Trial Network, which is also one component that is funded through HEAL, was to actually evaluate the effectiveness of community pharmacies for delivering buprenorphine to individuals with opioid use disorder. And the results show that these community pharmacies in rural areas had as good outcomes as those patients that were being treated by specialized clinicians in their site. So definitively access to pharmacies, which most rural communities do have, provides us a means to actually use that as a way of treating individuals. The other issue that happened and has made things much easier is that in March 13, around March 13, the DEA relaxed its rules on how a physician can prescribe buprenorphine. So in the past, you needed to go physically to see a doctor. Imagine you're in a rural community, there's no doctors that are waiver for buprenorphine. So there are none, so you couldn't get it. Now the DEA allows you to be initiated on buprenorphine through telehealth. And that has opened up the possibility of giving access to treatment to rural facilities. And when you were asking the question, I just smiled at SMIRC because we obviously also have another area of research, which is how can we use innovations to change things. And I was just recalling that one of the programs, the small businesses grants that we got requested was for the use of drones to deliver the medications in very inaccessible areas. And my perspective is let's look at innovative ways of solving problems, because the technology is changing in so many ways so rapidly that let's take advantage of it where it actually, and if it leads to better outcomes, let's use it.
Totally with you on that. And again, if there is a silver lining, we have been forced to take stock of whether some of the ways we've been doing things, which we can't do so well under COVID-19, could actually be transformed into something better. And we will learn from this, and we will change the way we approach so many things in health and medicine as a result. And certainly opioid use disorder ought to be very high on that list. I think we have time for just one more question. So let's shift to this question. What is the HEAL Initiative doing to promote prevention of opioid use? We would love not to have people falling into this terribly difficult circumstance. How do we keep people safe so that this doesn't happen to them? What's HEAL doing about that?
I'm glad that they asked this question, because I think that we've focused a lot on treatment, which is very important, but prevention is as important. And prevention, as it relates to the opioid epidemic, has many layers. Obviously, preventing people from overdosing, that's one. But it's also preventing people to become addicted, that's another one. And then it's preventing people to getting exposed to opioids. So as it relates to the prevention of overdose deaths, the most powerful tool that we have is the proper distribution of naloxone. And that has saved an enormous amounts of lives. For the second one, how do we minimize the likelihood of people becoming to opioids? This is where the initiative that is aiming to provide alternative treatments that for the management of pain that actually minimize the risk of addiction becomes so important. Because when we're speaking about, we speak about pain, right? It initiated the opioid crisis. We didn't have treatments. And if we don't address those needs, we will have people that will go to a black market because they need to address how the dysphorogenic and very uncomfortable feelings of severe pain. And any one of us that has had it can understand that. And then there's the issue of prevention. How do we prevent not people that are going through pain, but people that want to experiment with drugs and that get diverted opioid analgesics or start to take actually heroin because they actually either want to get high or they want to escape. We have this sense that people just take drugs because they choose to have a good time. That's the case in some instances, but in many instances, people take drugs because they are hurting. And this is not just physical pain, they are hurting, so they need to escape. And I think that element is one that I'm very sensitized, because with the COVID pandemic, we're stretching our system in terms of adults, children, and adolescents, and we've seen it in terms of the increases in anxiety and in depression and also in suicides linked with the COVID. So those are factors that are going to put a trajectory in a young person, in a teenager or a young adult, for higher risk of substance use disorders. And if we do not pay attention to those preventions, then once we control with vaccines the pandemic, we will have this huge gap of mental health needs. So what is HEAL doing? We have many, it's a comprehensive array of strategies that aims at prevention, because it's so layered. There is prevention specifically targeted, for example, to the transition from adolescence to young adulthood, which is the period of greatest vulnerability of uptake of opioids as drugs of misuse. We're also targeting minority groups that may be at very, very high risk. And we were discussing the high mortality risk that we're seeing in American Indians and Alaska Natives. So we're targeting there. But we're also targeting children and adolescents to be able to understand and intervene in factors that makes them more vulnerable. And that relates, of course, genetics are very important here, but also how your upbringing, your social circumstances, whether your mother took drugs when you were pregnant or not, and understanding those influences on the human brain and how that in turn develops into vulnerabilities for mental health conditions or addiction or resilience is, I think, a fundamental area of science that will help us tailor prevention interventions more effectively.
Yes, very important that we include that in everything we're doing in HEAL. Well, we need to wind up. Today, we've shared just a sampling of some of the issues that NIH is wrestling with regard to addressing the crisis of opioid misuse and overdose, as well as other drugs that are now very much part of the challenge. We shared just a few samples of questions we received about the HEAL initiative, and they reflect the high level of engagement and commitment we see in our community of researchers, providers, and patients, many of whom are part of the presentations in this particular summit. If you'd like to learn more, and maybe now this will appear on your screen, go to heal.nih.gov. There we have an opportunity for you to ask more questions, not just of me and Dr. Volkow, but of the research community and all of our partners across government and communities nationwide. Here's another website at the bottom of this slide. If you want to send us thoughts and suggestions through something called the HEAL Idea Exchange, you can see that. That is NIH heal.nih.gov.com. Kind of a mouthful, but you can copy that down. We'll leave it on the screen for a minute. So all of these developments and more give me hope in the face of clearly a very difficult year. But we still have the capacity to work together. We are resilient. We are people who have visions and dreams, and we are determined to put an end to our nation's opioid crisis. Thank you so much, Nora Volkow, for joining me in this discussion today. I am wishing the very best of health to everybody listening. And Nora, I'll give you the last word of anything you want to say to this assembled group.
Yeah, no, Francis, first of all, I want to thank you for your incredible leadership and your support amidst the COVID, that you're actually keeping your eyes on this crisis and your ability to bring everyone together. And that's quite extraordinary. I think that we are in the basically at the crossroad, as I say. We have the opportunity to make changes. And I do hope that the after times of the COVID pandemic will bring forward a more equitable system where people have basically the opportunity of better health, where they have the resilience, they are given the chance for resilience that maximizes their life happiness and productivity. And I think we do have a chance to do it. And I think science is an extraordinary tool.
Well, let's bring all those tools to bear on this really critical problem. And thank you, everyone, for listening. And we do send you best wishes for the success of this entire summit. And many thanks to all those who worked really hard to put it together, even in this virtual format. That's it from us. Thank you so much.